we have Professor BetrandTombal from Belgium, who's speaking to us about prostate cancer at the ANZUP Annual General Meeting 2015. Welcome, Bertram. So I think we'll start off by taking a helicopter view of prostate cancer, and just thinking over the last 10 years, what do you think are the biggest advances in prostate cancer, perhaps firstly in the localized setting and then also in the metastatic setting?
So if I look at prostate cancer and what we have achieved in the last 10 years, I would say, is that we have moved away from stage definition to biggest challenges, and basically realized that patient could be spread into three groups. The group that doesn't deserve any treatment, which is basically the price to pay for a quite inefficient screening and diagnostic program, all the Gleason 6, low PSA. In many countries now, we do recognize that these people should be left without treatment and just manage. The second, and in contrast to those that we overtreat, we have realized that the other one were clearly untreated or poorly treated, because what we have learned is that in contrast to what has been done for the last 10 years, which was basically using androgen deprivation therapy alone to most of these patients with locally advanced metastatic disease, if we want to make them live longer, we have still to use that androgen deprivation therapy, but we have it to combine it with more radical strategies. Those with locally advanced high-risk disease, clearly we have to combine hormonal treatment with radical treatment. Radiation therapy, radical prostatectomy. Where the heavy loaded metastatic one, we have to combine this hormonal therapy with chemotherapy. That is the result of Charted Stampede. But you understand that these two groups are not clear-cut. And in between, we have the group of patients we focus in most of the work now, which is to do what do you do if you are metastatic, but it's only one met? Should you receive hormonal treatment plus radical treatment or the met, or should you receive a prompt combination of chemo? But basically, this is how we have moved from doing prostatectomy to everybody, hormone therapy at first sight of recurrence, hormone therapy when your disease was a little bit advanced, to a more precision approach, which is no treatment for those who don't need a treatment, and a real treatment for those who need a treatment, meaning combining the historical androgen deprivation therapy with radical or chemotherapy treatment, or even in the future with both at the same time in selected patients.
Mm-hmm. Now, if we just drill down into some of those scenarios you just mentioned, what if you have a frail elderly patient with metastatic disease? There's some situations where you'd not actually recommend any therapy in that situation.
So, first of all, what will drive immediate treatment, still at this stage, is symptom and life expectation. Meaning that if you have symptoms from your disease, you need immediate treatment with a palliative endpoint. If you are fit enough to live for another 3 to 4 years, because this is what you can get from metastatic prostate cancer, you would deserve patient. This is a field where we've been making a lot of progress. This is what I will call geriatric oncology. Like in Europe now, all the elderly patients are checked because we believe that many of these are called frail, where actually with a minimum improvement, they could be moved to frail to normal and get a treatment. So that is where I believe in metastatic cancer, the space for active surveillance or watchful waiting does exist, but only if claiming that somebody is frail has been made by a professional environment, because many of the frail people actually can be improved and then started on treatment.
So now taking the other end of the spectrum, a young patient in their late 50s with a Gleason 9 cancer, normal bone scan, CT scan, but PSA 20, are there any other investigations that you'd recommend in that scenario?
So if today you are in your early 50s, you're working, you're fit and well, you care for your health, and you do a PSA screening, and the result of that is that you are getting diagnosed with high-risk localized disease, meaning Gleason 9, even 10. That is really where we want to tell you we need to focus our energy, because you are the one which unfortunately represents 50 to 60% of the deaths for prostate cancer. And you are the one for which we know the standard approach, meaning radical prostatectomy plus minus external beam radiation plus minus hormone versus hormone plus versus radiotherapy. It's okay, but it's not good enough. And I see the progress that we can make on 3 axes. The first one is we need to get a better evaluation of your tumor burden, not only in terms of local tumor burden, but in terms of metastases. And in that group of patients, clearly, I would recommend to seek second opinion for more modern imaging technique, whether it is MRI, all-body MRI, PET, choline, PSMA. These are competition questions, but I would recommend that you get one of these to really be sure what kind of tumor we have. And then why not? The next step is to embark into clinical trial where in top of the standard treatment, you would have the possibility to assess what's called metastasis targeted therapy, so that if, for instance, on top of your prostate cancer, we find one single bone met in a rib, you've got stereotaxic radiation therapy plus your radical prostatectomy. You understand that we are moving away from standard treatment, and this has to be done in a strict clinical trial framework. The second axis we want to make progress is what is the biology of your cancer. And that's where, as a urologist, I'm a fervent defender of radical prostatectomy, because it gives you the possibility of having an exhaustive pathological review and really look at those driver mutations we know confers a very, very severe prognosis, and that may be addressable a few years after when you will be progressing. And the third axis for which we're doing a lot of progress, I believe, is to understand the determinant of survivorship. How can we help you coping better with side effects of the treatment? Like I know in Australia, it's also very popular. How can we get through this lifestyle adjustment that maybe you missed before? Quit smoking, eat better. So it's sometimes in the era of precision medicine, we often talk about modern imaging, modern drug, but I think it's more importantly, it's also modern survivorship issue. When you're going to have like 15 to 20 years survival, it's important as well. So I would say that basically, if there is one category of patient I would like to focus the rest of my life, it's clearly those guys that go to the PSA screening, do the effort, and are those diagnosed with the aggressive prostate cancer, where we have to put our energy, because these are the young guy that's going to die from it, usually through a long, debilitating disease, and we must help these people now.
And so even in the presence of metastatic disease, you would not rule out a radical prostatectomy in some patients?
I would not rule out a local treatment. So the definition, one of the problems of prostate cancer is that the definition of extent we use, which is metastatic, non-metastatic, localized, locally advanced, doesn't reflect at all the biology of the disease. A man with 4 bone metastases may be actually less aggressive than one man with 1 metastasis. Just take the example, it's 1 liver metastasis. We know that, it's obvious. So we need to understand much better the biology of the disease. And as physicians know, we have the ability to make what I would call an educated guess about how long they will survive. If we expect their survival to be quite good, we should think about treating the primary. And actually there are several trials, the famous Stampede trial that everybody know mentioned for the role of docetaxel in metastatic is also investigating the role of treating the primary in these metastatic patients. In Europe, we are conducting a trial, the name is PEACE-1, where in patients with metastatic prostate cancer, we give ADT plus abiraterone plus local treatment. So all of this highlighting the fact that we believe that in men with what I would call the low range of metastatic burden, there is a role for local treatment. Now, what is the best local treatment? That is a corporatist discussion. I'm a urologist, I'm going to tell you it's prostatectomy, and you won't believe me, and you would be right, because I believe that the difference between radiation therapy and surgery is, first of all, a philosophical decision. It's how you feel, what you want to. But most importantly, it is a quality control decision. It has to be done by the right people, the right team. Then it's okay.
Can I ask you the endpoints of that PEACE-1 study? Is it a survival endpoint or a quality of life endpoint?
The PEACE-1 study, as well as the Stampede study, are primarily designed for an overall survival endpoint, which is, I believe, still extremely important in the present regulatory reimbursement environment. They are both include as second endpoint quality of life. You know that in many countries in Europe, the base of estimating the performance of a drug is based on QALYs, meaning a mixture between how long you will live, but how well you will live. So quality of life for me is a major endpoint.
In your own practice over the last 10 years, have you seen the pattern of spread of advanced prostate cancer change in any way with our modern day therapies?
In the last 10 years, first of all, patients live longer. Okay, so that's clear. We're seeing more and more elderly patients that's getting through multiple lines of treatment. So we see change in the pattern of metastases. We see more and more patients developing visceral disease in the end. But overall, at the initial step of the disease, it is still primarily a bone disease. So that's why treating the bone is so important. What we see is a change in the comorbidities of the patient. We used to see more fit patients now than before. And it's not rare that we discuss in MDTs patient in the 90s with metastatic prostate cancer who's still coming to the outpatient on their bike, still playing golf, and still enjoying life with their grandchildren. So these are challenges in terms of administrating drug with, proper delivery.
So have you seen unusual sites of metastases, for instance, peritoneal disease or epidural spread?
No, I mean, there is something also is that the imaging is changing. I remember when I started my residency, we would do like a TURP. We would find a Mostophy grade 3 prostate cancer, ask for a bone scan, and that's it. No, we do. A good example would be, for instance, lung metastases. Why do we see lung metastases? Because instead of doing abdominal CT, we do thoracoabdominal CT. We started doing thoracoabdominal CT in my institution in 2003. And we look back at the CT we did between 1998 and 2003. We haven't seen one man with lung metastases. Normal. We were doing abdominal CT. Since we start doing a different kind of exploration, we see different kind of disease. It's the same for liver metastases. And so it is still primarily a bone disease, but we see change in the pattern. But whether that change of the pattern reflects a different natural history beyond the fact of multiple lines of treatment, or does it reflect a better assessment with better imaging technology, that's another question.
Okay, now changing tack again. For the young surgeons, the young oncologists who are looking for an area of specialization, would you recommend the prostate cancer field?
So you're asking me a very interesting question, whether prostate cancer is a sexy area for a young physician. I think it is, but I would not limit myself to prostate cancer. I would do GU. I think that we have been making progress in oncology through cross-fertilization. Cross-fertilization between specialty. If you ask me what is the most important benefit of docetaxel, it's not its efficacy in prostate cancer, which is still very minimal. It is the fact that it has transformed prostate cancer from a monodisciplinary specialty into a multidisciplinary specialty. So you have cross-fertilization between the urologist, the radiation oncologist, the medical oncologist, the physiotherapist, the pathologist, as much as you can have. And we do not treat bladder cancer today because in 2004, 2005, we start sitting with the medical oncology to speak about prostate cancer. First. Second, there is cross-fertilization between cancer type. More and more, and if you take, for instance, the area of immune checkpoint inhibitor like PD-1, PD-L1, you're going to treat a cancer based on its biology. It looks like science fiction for many of us, but when you imagine that we find up to 10 to 15% of BRCA mutation in castration-resistant prostate cancer, we find PTEN or RB mutation in 20% of the patients. So yes, it will evolve. So I would not focus on prostate cancer only. Yeah, like I do. I mean, I would focus my academic activity, but from Monday, Tuesday, Wednesday, I'm not treating prostate cancer. I'm treating GU cancer. And it's very funny when, like yesterday, we had that very nice lecture by Dr. Rini. I learned a lot from this lecture on renal cell cancer. And I say, wow, these are concepts we could transplant to other GU cancer.
We were talking about collaboration at a local level. What about collaboration at a national, international level? Have you seen that change in the last 10 years, and do you think that's very important?
The collaboration at the international level has improved a lot, simply because not a single organization can run trials that will bring an important message. And I'm going to give a good example, which I give them quite often, although they are my neighbor and French. This is the GTUC trial, which usually they are powered for France. So they say, okay, we can do a 300 patient trial. We do that trial. But the problem when you do national level trial, you don't get enough patients, and they're not conclusive. And the problem is that a meta-analysis made on 5 inconclusive trials is still inconclusive. And everybody realized that. And that's why I know there is an effort that between the largest organization like EORTC I represent, GTUC, MRC, US, ANZUP, we share our portfolio to make the difference between the study that are selected transactional research trial that can be done on national level and those where they are an important question and we joined force. And the EORTC participating to the ANZUP ANZARA trial is a good example. At EORTC 3 years ago, we realized that there was certainly the need of doing a trial of hormone therapy plus one of these novel anti-androgen in combination with radiation therapy. And we planned and started to discuss with several companies to do that trial when we learned through our colleague that ANZUP was conducting that trial, where 10 years ago people would have competed at the level of the industry, do the similar trial with a similar drug. Now everybody realized, no, that's a waste of time. Let's better find a way to work. And that's where regulatory hurdles are getting in the way. And that's where clearly what is starting to work very efficiently is what I would call a non-US network, where clearly we, being smaller country like Belgium, Australia, we realize that we have to soften the regulatory procedure, and that's why we're trying to exchange and work on a regular basis. The breast cancer people did that. They started the big group, breast investigation group, and they conducted trial with 12,000 people, where we still hurting to get 1,000 patients on trial. So really, this is the only way you can do it. Also, it's important in terms of HTA, health economics. So clearly, that's the way to go.
So now, talking about patient-centered outcomes and quality of life, what do these mean to you, and how do you incorporate them in your own practice?
So one of the problem in prostate cancer nowadays is that for probably 90% of the patient, meaning those that are treated outside registry and outside clinical trial, we have very, very few evidence of the quality and the efficiency of the healthcare that is delivered. And one of the reasons is that we don't speak the same language, we don't do the same thing, we don't monitor the patient the same way. If you have a boat with an Australian flag and you come to the Netherlands and you cross a boat which has a Netherlands flag, there won't be any accident because you use the same code. So we need to enforce the fact that we speak the same language. That's first. So then when we describe things, we describe it the same way. And then something which is even more important is that most of what we do, and that's actually extremely obvious if you look at the urological literature, we look at physician-reported outcome. As a physician, my patient is doing great. No, it's no time to move to patient-reported outcome. So when we look at the urological literature, and also medical oncology literature, it's striking how much we evaluate things on physician-reported outcome. My patient is doing great. I think it is no time to ask the patient. But you should not simply ask, "Oh, are you doing?" or "Oh, do you have any leaks?" or "You're still potent." No, we have to use patient-reported outcome tools, specific instrument, and there are multiple of these instruments. But we have to decide on a nation base, on a group base, that on top of the physician-reported instrument, we need to also ask the aspect of the patient. Let's say you have a radical prostatectomy for an intermediate risk prostate cancer because you choose to do so. And after 6 months, your PSA is undetectable. Everybody's here with, "Oh, great, yeah, it's great." But if that guy is now absolutely impotent and absolutely incontinent, that's not great, it's a catastrophe. The problem is that who does control that? And that's why one of the future we do that already in clinical trial. We do that in registry. So for us, we know what the benefit we can have. Now the effort has to be done into implementing this to any single patient who has a treatment, including active surveillance for prostate, because this is the only way we're going to be able to measure what I call the no-do gap, meaning the gap between what we know we learn in clinical trial and what's really happening in everyday life. And filling that gap require first to speak the same language, including asking the patient's opinion, and second, collecting and analyzing that information. But there is no reason to have a national registry if you don't have a standard way to measure sync.
If Bill Gates gave you $30 million, what sort of trial would you organise in prostate cancer?
So if Bill Gates is giving me $30 million, I would say, please give me more, because it's so expensive that 30 million is not that enough. I think that what I would do first is invest that money into having a reliable, cheap, reproducible way of identifying who will die from prostate cancer. And so to answer the most important question, who needs nothing? Who needs a simple prostatectomy done by a brilliant robotic surgeon with a minimum of side effect? And who needs a more sophisticated, still today hormone therapy based treatment plus something else? I think that we have a good idea of the treatment. We don't need Bill Gates' money to develop new drug. We can use the industry money for that, because this is their business. What we need is use Bill Gates' money to make the better use of the industry drug. And that would be, and actually you have already 3 consortium that are working that way, one being sponsored by charity. These are the East and West Coast Dream Team in the US, and the SPECTA consortium in the EORTC. Just to give you an idea, the SPECTA Color, which is the colorectal screening platform for iris disease, is sponsored by Allianz Booth, the pharmacy, as part of their corporate responsibility program. So I think that more and more of company, charity, realize that identifying who needs what, rather than what works the best, which is the industry work, is highly expected.
So ANZUP, it's a young trials group, less than 10 years old. EORTC has a lot of experience. Is there anything that you can recommend that ANZUP should be doing in the next few years?
So it's been now my 3rd time in Australia, and Australia is an extremely energetic country. I mean, you feel that it's striking to see such a big space, only 25 million people with a lot of energy. So, and ANZUP is into that move. So clearly people try to get things organized. What I like about ANZUP, and really you should build up even more, is to move away from the standard trial and incorporate everything that make cancer research so important, which is quality of life, health technology assessment, efficiency in delivery care, multidisciplinarity. Because this is by having all these people working together that you're going to create a great thing. And then it's because of that energy and because of that new way of seeing things that maybe old organizations like ourselves at EORTC, we now recognize the benefit of working together with ANZUP. So clearly keep growing the way you grow, and you're going to be successful.
Now, moving away from cancer, we have a personal question now. This is a traditional ANZUP question that we ask all our international guests. Is there something about you that is not generally known that you can share with us? Any secrets, perhaps?
I am born in a very old city in which my house was built in 1554. And actually, in that city, there is a very, very famous carnival, which is the oldest in the world, where every Mardi Gras we dress with an extremely traditional costume, which has been the same for 800 years. And once you are dressed, you can't stop until you fall. It usually takes 24 hours. And it gives you at least the quality we need for that kind of career, which is resilience and abnegation. And I think once you have that, that's okay. I would say that the major problem of an academic life is that you have no secret life because you have no time for that secret life. But otherwise, this has forged my character, and I like that you can't change. And probably that's why I'm so much involved into clinical trial, is that you don't change tradition with solid evidence. And this is a trend we are seeing, unfortunately, now in medicine, where people change from one day to another. No, you change only. In my carnival, if we want to change something, we need that the 1,000 participants agree on, and we have to really demonstrate that it is for the sake of the establishment. And that's where I like things to be.
That sounds like a marvellous tradition. It'd be fantastic to be able to introduce that here as well, if possible. Professor BetrandTombal, thank you very much for joining us this morning, and I wish you all the best for your visit to Australia. Thank you.